Excellent presentation. Okay, I do welcome Dr. Farley. Okay, I was very remiss when I came down from Nanaimo yesterday. I forgot one thing. My baseball cap. My red baseball cap with the Hep C pin on the front. Dr. Farley and I go back to proactive political patient advocate. And we have been down to the legislature with our bullhorn, our caps, and our fists to access care and treatment for our patients with hepatitis C. So I go back with Dr. Farley. I've spoken alongside him on many different occasions on Hep C World Hepatitis Awareness Day and World Hep Day. And what I'd like to do today is to introduce Dr. Farley. Now, Dr. John Farley, he was born in British Guiana. He trained at the University of Waterloo. He achieved his MBBS undergraduate at the University of Lagos, Nigeria. He obtained his formal degree at the University of Alberta in internal medicine and infectious diseases. Dr. Farley has a distinguished career in medicine when accepting a position at BC Centre for Disease Control, provincial epidemiologist, as he spearheaded the campaign to have all children in British Columbia immunized for hepatitis B. Dr. Farley's passion for helping those, and I must indeed say it is a passion, with infectious diseases led him to the challenge of treating those with hepatitis C and HIV. In Canada, he worked for Ministry of Health Bureau as a chief of surveillance of HIV/AIDS and is currently the Infectious Disease Consultant in the Pacific region for Correctional Services Canada. Dr. Farley has 2 private clinics in Vancouver and Abbotsford where he treats patients with Hep C and co-infection, HCV, HIV. He's an incredible advocate for the accessibility of care and treatment for those infected with and affected by hepatitis. So at this time, I would like to bring Dr. Farley to the podium. Thank you. This only works for just, okay? And I have to just up and down here. Thank you.
Well, thank you very much, Joan, for that introduction. And thank you very much for the opportunity to participate in this very important forum. As Joan has mentioned, we go back a long way, and I think I'm still looking good. Both of us, actually, right? And I must say how much I admire the dedication to her profession that Joan exudes. She's been a tireless fighter as well, and I really appreciate the work that she is doing. She's putting a lot of us to shame. I would thank Doug as well and Joan for trying to track me down and trying to get this going. And I must say that I'm very, very pleased to be here today. And I wouldn't have missed it for anything in the world, although I think some things were conspiring against me, including the weather. I started out about 7:30 this morning. I thought I didn't want to go to come by the ferry because I said it was too much of a long drive. The flight was cancelled, postponed. They asked us to keep waiting until they will announce whether it will take off. After about 10 o'clock, I said, it doesn't look like it's a go. So I decided to drive to the Swanson ferry terminal. I was the 5th in line before they shut the gate. Then I said, no way, I'm going to the airport. I asked Wendy, when we've spoken to her, to try to get me a flight. They said the flight was booked. And then I flashed my Super Elite card, and I said, okay, I'm going to get on. Anyhow, so here I am, and very sorry to be late, but thank you very much for this opportunity. I was asked to speak on the accessibility to care and treatment for hepatitis C, the challenges we face in BC. And as I was trying to determine what I was going to say, I thought I'd draw from my experience working in Correctional Canada, in the institutions. I'm on contract, which means that I go in and out, my get out of jail card. However, part of the challenge we face is that because you're a contract physician, you're not an insider. So you're just always on the periphery, so always trying to fight to get in. I work in about 8 or 9 institutions right now, and this means that I see inmates in the prison, as well as you will hear a bit about the program we have when they get out of prison. As I was preparing for this talk, I thought that a case that I saw about 6 or 7 years ago exemplifies lots of the issues we face, unfortunately, still today. One afternoon, not unlike an afternoon like today, I was heading out from one of the institutions, actually Matsqui, and I heard a call, heard my name, Dr. Farley, can I speak to you for a minute? When I looked back, it was a gentleman called Ray. He was the social worker liaison for the prison and the community. How am I going to operate this? Okay. He said, when he called me, he said, I'm retiring in a few, basically it was a few months, and I just wanted to, one day, to be able to tell you thanks. I said, thank you for what? Then he said, do you remember the day of this case, blah, 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 blah. So I'll just recount the case for you. And this, as I think exemplifies quite a lot of the issues we're still facing. This was a gentleman I saw starting early 2002. For the sake of confidentiality, I will call him XYZ or XYZ. At the time I saw him, he had just about turned 30. He was first seen at one of the institutions and referred to me to evaluate for treatment of his chronic hepatitis C virus infection. Like most of the folks in the prison, he acquired the infection through intravenous drug use. Unfortunately, he had cirrhosis, and unfortunately, in those days, we were using the Rebitron, three shots a day, and it was a rough treatment. I explained to him that, the chances of response were pretty poor. However, this was his only chance. And true to form, he says, no, I want to go for it. We started his treatment, and by 12 weeks, he decompensated. In other words, he got very jaundiced, abdomen got swollen, developed ascites, and could no longer take the treatment. So the treatment was discontinued. His only recourse, because he was that advanced, was a liver transplant. I tried to get an appointment for him at our BC Transplant Society. Needless to say, in those days, they did not even consider a prisoner to be valued for a liver transplant. However, they did say that if he could remain drug-free for 1 year, they would then look at evaluating him. I conveyed this to the gentleman, and he said, yes, I want to get out of here. I'm looking forward to getting out. So I'm going to stop doing drugs. In fact, he had started a program in this regard, and he was on methadone. He says, I'm going to go one step further. I'm going to stop the methadone just because I want to get that transplant. About 8 months into this waiting, we continued to manage him. About 8 months into the waiting, he got very ill. And I was driving home one night. I got a call from the institution. This guy is sick, what should we do? Knowing him, I said, rush him to the hospital. He went to the regional hospital. And within 3 or 4 hours later, I was advised he was shipped back to the institution. The following day, the same thing happened. I called the institution, spent about at least an hour Here's a guy who is very sick. He's got cirrhosis. In all likelihood, he's decompensating. He needs to be admitted. For whatever reason, he spent a few hours in the hospital and was sent back to his cell. Well, we have a sort of a healthcare facility, so he ended up the night there. I was called about 7 or 8 p.m. that night, asked for him to be put on some antibiotics, because I knew I was going to be there in the morning. Went in the morning to see him, and clearly he was very far gone. Spent about most of the morning, I went for a clinic, but spent most of that day trying to get him into an ICU. And there was no place. They had this looking for beds. I was able to get a hold of the head of the GI division at the Vancouver General Hospital, explained to him what had happened, that he was on a wait list to be considered for transplant. In fact, the letters and the information we had sent were reviewed, and it was pending an outcome by the review board. So he says, okay, why don't we send him to Vancouver? Arrangements were made to ship him to the Emerge at VGH, and then I went on to do the rest of my clinic. I was told later in the afternoon that this gentleman had died. An ambulance had come to pick him up, to take him to the hospital. Unfortunately, it was a local ambulance, and they did not go to Vancouver. It took another 3 or 4 hours to get the Vancouver ambulance, and by the time everything could be arranged, and he was put on the ambulance, just by the gate, he coded and could not be resuscitated. Ray, he said, I needed to tell you this. If ever there was a guy, I've been in this service for over 25 years, who never got a break, this was the guy. You see, his mother was a street person. He went to school, and he was, quotes unquote, disruptive. Got into bits of a trouble, ended up in juvenile detention centers, and it's happened to most of these folks. Did some petty crimes, got involved with some minor drug stuff, ended up with his first federal incarceration, and that's how he ended up at Matthew Institution. When I evaluated him that morning and realized that, he was far gone, I asked him, and we asked, is there anybody we can call who you'd like to speak to? The only person he could think about was another social worker in Edmonton. We put through a call to that social worker. Unfortunately, that day he wasn't there. As I outlined, we called the ambulance. The wrong ambulance came. Ray basically said, if ever, as I said, there was a guy who didn't have a break, this was him. And at least I wanted to thank you for trying. This, I hope, will be the theme of what I hope to outline over the next 40 minutes. Because unfortunately, stories like these may not be as tragic an outcome, but different flavors of these are still occurring. What are some of the challenges that we face? First, let's look at the correctional institutions. We know that chronic hepatitis C virus infection is a very important public health problem. We know that they largely occur in people who, now they're occurring mainly in people who have done intravenous drugs. It's estimated that in most corrections institutions, you will have anywhere from 23 to 86% of people who have done intravenous drugs and are likely infected with the hepatitis C virus. We know there's a congregation of hepatitis C virus infection in the prisons, yet there's a disproportionate amount of resources that are being spent to deal with, to study, and to address the problem of hepatitis C in vulnerable populations like our prison population. We in Canada have the dubious distinction of being third in terms of our incarceration rate, and the companies we keep are those of the United States. They're the ones that are a little higher in terms of the rates of incarceration, and pretty soon, the rate at which we're going, I would not be surprised if we approach their rates of incarceration. From data that I could glean, the total number of incarcerated population in the federal system was about 30,000. There were basically nearly 300,000 of convictions of adults, 2/3 of whom would have no term sentence. A third of these would have a term sentence, and 5% would end up in the federal institutions. So it's worth noting that at any one time, those with criminal records or prisoners, those who have sentences, about 5% are going to be in the prison. The vast majority are going to be in and out of the prison. In 2001, and this is based on the latest set of data I could get, the federal inmate population was about 15,000, about 15% Aboriginals. In 2006, 13,200 were in the federal penitentiaries. So basically, the rates of admission to these institutions is not getting any better. Now, what have been some of the reasons that have been advanced for not dealing with the problems in the prison settings? We say that most of those are former or current drug users, and they don't care about their health. The treatment regimens are long, they're complex, they would require commitment, and inmates don't have that sort of a commitment. The regimens are usually associated with significant adverse effects, and the inmates may not tolerate them. The likelihood of reinfection is high. The costs are significant, and the burden of disease high. So we're not going to deal with this problem. But let me remind you that legislation dictates, and it is the law, that care consistent with community standards should be afforded to all inmates. Their rights of congregation, their rights of where they can stay have been taken away, but not their rights to public health or to good health care. So it is their responsibility that they get the same type of care, equivalent care afforded to those in the community. About 5 or 6 years ago, I decided to look at the folks we had treated in the prison setting and to challenge the notion that these guys are irresponsible and don't respond to treatment. Basically, we looked at the treatment outcome of those who had been treated for chronic hepatitis C virus infection over a 2-year period, using initially the 3 times a day interferon plus ribavirin, and subsequently the pegylated interferon and ribavirin. We published the findings of this review in the American Journal of Public Health, followed it up with 2 or 3 other publications in different journals. I'm stressing this because they're all peer-reviewed. What they have shown, and shown quite clearly, that given the right setting, we have looked at over 150 people who were treated. Over 66% completed the treatment and had what we would consider a satisfactory an SVR. In fact, the results rival even any of the registration trials results. So, I think we have put at least to rest the concept that these guys don't care about their health and would not come forward for treatment if afforded the opportunity. We demonstrated and continue to demonstrate that treatment of hepatitis C virus infection in the prison setting is feasible as well as very effective, and in fact very cost-effective. Interesting to note that we did not have fibroscans, we did not have ivory tower settings, office where they could come in and sit and have coffee. We had one physician who went around to 8 different institutions and nurses who worked based on some protocols we prepared. And this was demonstrated to be a very cost-effective intervention. We were able to treat many more cases than many of our tertiary cares treat in 1 year. And the data are out there to prove it. What are some of the challenges we face? Recognizing the magnitude of the problem, I am really appalled at the indifference that is shown by our powers that be, our medical establishment, our funders, as to what we should be doing to manage hepatitis C virus infection. I'm just back from the guidelines meeting in Montreal last weekend, and Rob was there as well. It appears to me that our folks who are making decisions are embarrassed to mention the word prison. We have about 30% of our problems occurring in our prison setting, yet as we look at our CASL guidelines, nowhere does it mention that special efforts must be taken to even study the problems as to how we can deliver a program in the prison setting. I would have thought, and I found from my experience, that by going to where the action is, that's where you'll find the action. If the hepatitis C is in the prison setting, that's where you're going to find it. We expect to solve the problem by setting up appointments 2:45 Friday afternoon, March the 6th, and guys who don't even have a bed or a clock. And they must come whatever street in some tower, and we expect to have a good program, and are wondering why the heck aren't we reaching people. We have the vast majority of folks who are in the prison setting who have mental health problems that need to be addressed. We have the vast majority of the folks who need to have their addictions issues addressed. This in the context of managing their hepatitis C. Now, what are some of the barriers that we found in terms of getting to managing and treating those with Hep C? One of the major barriers was the capacity for continuing the treatment and follow-up on discharge to the community. When I first started working in the prison setting, we were treating on an average of 3 to 4 people per year. That was about 10 to 12 years ago. We were told you could not start a person on treatment unless they had less than a year, more than a year left in their sentence. Because the other reasons I outlined, as well as the fact that if they get discharged, there's going to be no continuity of care. So what did we do? We decided on our own, and I stress on our own, to start a project called INCORS, the Inmate Community Health Reintegration Services Project. It was established in 2004 with the idea that it would provide support in accessing healthcare needs, connecting patients to physicians so that they can continue their care once they get out into the community, facilitate the continuation of treatment of Hep C and HIV, and assist in directing individuals to different agencies, because we know when they come out, it's a dog's breakfast trying to figure out where you're going. The birth of NCORS was by necessity. I must say how pleased we are, and we have members in the audience here from the pharmaceutical companies industry. We got some funding initially from the sharing. They were sponsoring the medications, and it was for a small amount to hire a nurse, a sort of a counselor, to be able to call patients in. It was about $30,000. This was subsequently followed up by a grant from the other company when they got on board. I'm stressing this because we applied and we tried to get funding from the Ministry of Health, from the Vancouver, whatever board we call it. Over the last 2 or 3 years, we have tried to get funding from Coastal Health, whatever the group is called in Abbotsford, I can't remember, but they make us waste their time and write a whole heap of project proposals and don't get anything. So we got some funding. And I am not going to sit here and apologize or stand here and apologize for getting funding from industry when the government is doing absolutely nothing about it. The phases of the project were basically looking at a pre-release setting where we would get information as to when they're going to get out into the community. We worked with the halfway houses, and basically there's a community supervision phase. Now, the experience to date, one of my best movies is the classic The Good, the Bad, and the Ugly, and I always think of some way to bring that in. The good thing about this program is that many, through this mechanism, have been able to complete the program. Before this program started, we could not start people in the prison setting on Hep C treatment because there was no way to follow up in the community. Because it exists now, there is no excuse that we cannot start people. There is a program that we can continue treatment when they get out. The number of appointments is steadily increasing. You come to my office in Vancouver, Abbotsford, any day, about 10 to 20% are either inmates or former inmates or relatives of inmates or spouses or friends of inmates. I think this is very good public health because once we have introduced health-seeking behavior, then a significant proportion of those who have learned continue to practice health-seeking behavior. The data we looked at, and we published some of this, as of March 2009, we had seen in the setting 536 inmates. I can tell you over the last 3 years, we've been increasing average 15 to 20% per year. About 65% of the inmates who were discharged kept their appointments and continued their treatment. There have been fluctuations in terms of the referral rates, anywhere from 26 to 75% over the years. Making the point here that over 60 to 70% of those who we see and refer continue their treatments in the community. Over 200 up until 2009, had initiated Hep C treatment and either in the prison or when they got out because they had the workup done when they were in the institution. 43 had received provincial coverage for Hep C. 153 were referred by our network to social services. And if this weren't done, they could not get the treatment because they were quite a few of them were going to be sleeping under the bridge. When you ask for the address, where are you going to be? I'm going to be on Hastings Street. And there's no way we can complete Hep C treatment in a person who is sleeping under the bridge.